signs of bone destruction. Periodontitis is differentiated from gingivitis by the loss of attachment that is accompanied by bone loss. It is a continuous process of resorption and formation that occurs in the alveolar bone. There is a balance between resorption and formation, but when resorption exceeds the formation, the bone density and height are reduced. Bone level is an indication of past pathologic changes. Soft tissue changes are indicative of the present inflammatory changes. How the extension of inflammation takes place. Periodontitis is always preceded by gingivitis, but not all gingivitis progresses to periodontitis. So this is a normal gingival sulcus with a probing pocket depth of 1 to 3 mm. This is a case of moderate periodontitis where you have a probing pocket depth of 4 to 5 mm, where non-surgical management can be done, and this is a case of deep pockets, that is a severe periodontitis where the probing pocket depth is more than 6 mm, where periodontal surgical procedure is required. The transition from gingivitis to periodontitis, why it should happen? There is a change in the composition of the bacterial plaque that increases the number of motile organisms and spirochetes and decreases the cocci. The cellular composition of the infiltrated connective tissue T cell lesion is contained gingivitis lesion. When it becomes a lesion, it is predominated by B cells. Recurrent episodes of acute destruction over time takes place, that is given by Hichel et al. In 1976, and host resistance, that includes immunological activity, width of attached gingiva, degree of fibrosis, reactive fibrogenesis, osteogenesis, fibrin and fibrinolytic system. So this is a diagrammatic representation of the pathway of spread of inflammation in the interdental area. On the facial aspect, this is the pathway of spread of inflammation, where gingival inflammation spreads to the connective tissue and that spreads along the blood vessels and collagen fiber bundles towards the bone. Transeptal fibers are destroyed during the spread of inflammation, but they are reformed at a lower level. After inflammation reaches the bone, it spreads to the marrow spaces. The marrow changes are leukocyte and fluid infiltrate, new blood vessels, osteoclastic cells increase in number, and the bone surface is lined with house-shaped sliding. In the marrow, the resorption occurs inside the spaces, resulting in reduction in bone height. Bone destruction is not a process of necrosis, it is carried out by the viable cells. The amount of infiltrate correlates with the level of bone destruction. The distance between the apical margin of the infiltrate correlates with the number of osteoclasts with the alveolar crest. What is radius of action? Grant and Cho reported that locally produced factors induce bone destruction. Page and Schroeder reported the range of bone destruction is between 1.5 to 2.5 millimeters, and the bacterial plaque can cause damage. For angular defects to form, the width of the interdental bone should be more than 2.5 mm. Larger defects exceeding 2.5 mm may be produced by the presence of bacteria in the tissue. The rate of bone loss. Low et al. In 1986 reported that untreated periodontitis in Sri Lankan tea labourers, he saw an annual rate of bone loss of 0.2 mm in the facial aspect and 0.3 mm in the interproximal aspect. 81% of the individuals had moderate progression of the disease with an annual attachment loss of 0.5 to 0.05 to 0.5, and 11% of the individuals minimum or no progression of periodontal disease, annual attachment loss of 0.05 to 0.09. Chronic periodontitis is characterized by periods of destruction and inactivity or quiescence. During the periods of destruction, there is loss of collagen and alveolar bone. Theory is proposed for onset of destructive periods. Subgingival ulceration and acute inflammation. T cell to B cell shift increase the number of motile gram-negative flora and tissue invasion by one or more bacteria. So the bacterial enzymes and toxins are responsible, and host inflammatory mediators are responsible for bone destruction to take place. This is the mechanism of bone destruction that takes place. Whenever there is a bacterial toxin that is entering the body, the monocyte produces pro-inflammatory cytokines that will act on the precursor cell that will be differentiated, that will get activated. The rank and the rankle is activated, resulting in bone resorption. Bone formation. The areas of bone formation are present adjacent to the areas of bone resorption, and bone formation takes, that is called as buttressing bone formation. Bone destruction that is caused by trauma from occlusion. Changes can be produced in the presence or absence of inflammation. In the absence of inflammation, you can have angular loss of bone. That is, in the presence of inflammation, you can have trauma from occlusion. Bone destruction caused by systemic disease. Local and systemic factors regulate the physiological equilibrium of the bone. Generalized tendency for bone resorption exists. Bone loss is initiated by local inflammatory process. This is called as bone factor concept proposed by Glickman in 1950. That is, factors determining the bone morphology in periodontal disease. Normal variations can occur in the alveolar bone in the thickness, width, crestal angulation, thickness of the facial lingual plates, presence of fenestration, dehiscence, and exostosis like small nodules, large nodules, spike-like protrusion present. Bone destruction in periodontal disease. Two broad patterns of bone loss can occur: horizontal and vertical or angular. Horizontal bone loss, most common pattern of bone loss. Bone is reduced in height and it is roughly perpendicular to the root surface. The interdental septa and the facial or the lingual plates are affected. Factors determining the bone morphology in periodontal disease: trauma from occlusion, buttressing bone formation, foot impaction, localized aggressive periodontitis. This is the horizontal bone loss. Bone deformities and osseous defects. You can have vertical angular defects, osseous craters, bulbous bone contours, reversed architecture, ledges and furcation involvement. The angular defects or vertical defects which occurs in an oblique direction is usually associated with the intra-bony pocket. This is an angular defect. Goldman and Cohen in 1958 classified vertical bone defects into one wall, two wall and three wall defects. So this is the diagrammatic representation of one wall, two wall and three wall defects where the number of walls are present, not absent. This is a combined osseous defect where you have a three wall defect. This is the example of a diagrammatic representation of combined osseous defect. This is a two wall defect or a crater. So vertical defects can be seen when present in the interdental area in a radiograph. Three wall defects have been noted particularly in the mesial surface of the upper and lower molars. Combined osseous defects. Number of walls in the apical portion is more than the coronal portion. Osseous craters are concavities in the crest of the interdental bone confined to the facial and lingual walls. They constitute 1/3 of all the defects, that is 35.2% of all the defects, and 2/3 of the mandibular defects. They are twice as common in the posterior than the anterior region. Facial and lingual plates are equal in height, 85% of the cases, and remaining 15% of cases the buccal and lingual plates are higher. This is a two wall defect or an osseous crater where you can see a depression that is present between the buccal and the lingual bone. The interdental area collects plaque and it is difficult to clean. So the normal flat or a concave shape of the interdental septum in the lower molars may favor crater formation. Bulbous bone contour is exostosis and buttressing bone formation. Reversed architecture. Loss of interdental bone including facial and lingual plates without a concomitant loss of radicular bone. Plateau-like margins caused by desorption of thick and bony plate. This is a picture of exostosis. This is tori. This is a reversed architecture where the buccal bone is able. This is the furcation involvement, whether it is the involvement of bifurcation, trifurcation of multi-rooted teeth with periodontal disease. You can see widening of periodontal ligament space. There is an inflammatory, cellular and inflammatory exudate, epithelial proliferation in the furcation area, and extension of inflammation to the bone that is causing resorption of the bone and reduced height of the bone. This is the grade 2 furcation involvement. So factors influencing furcation involvement are trauma from occlusion, root trunk length, cervical enamel projections, and enamel pearls. So summary is: extension of inflammation from gingiva to bone causes bone loss. Pathway of spread influences the pattern of bone loss. The influence of systemic states on locally induced alveolar bone loss is called as Glickman's bone factor concept. Bone loss patterns can be horizontal and vertical, and osseous defects can be divided into vertical defects, craters, furcation involvement, etc. Thank you.